The next lecture is going to be given by Roman Huber. And Roman, I was thinking, how long do we know each other? And then I thought, since 2002, when I moved as a young assistant to Freiburg, Clinic für Tumorbiologie. And then I came to your office because I was fascinated about your work and wanted to get to know you. And then we had a short talk, and then you said, oh, let's have dinner together. So you were spontaneous, you invited me very cordially, and since then we have a strong friendship. You run the department of integrative medicine and I think hygiene at the University Hospital of Freiburg. And your topic is going to be phytomedicine and immunostimulating herbal medication and supportive phytotherapy. Thank you, Roman, for coming. And we are excited to learn what are your insights from the last years. Thank you.
Yeah, thank you, Boris, for this personal notes. And yeah, thank you for the invitation. It's a great place. I'm very pleased to be here. I start with a very provocative sentence. Maybe it's provocative, but do you know any medicinal herb which has no immunomodulating effects? This is actually a question. And if you consider that plants have metabolite substances to fight against enemies, bugs, and anything that want to eat them, then you can imagine, yes, every plant has something which is a bit toxic and is cytotoxic and reduces the growth of other cells. So probably there's no medicinal plant without immunomodulating properties. And I think this is very interesting for this discussion because we are now demanding clinical studies to prove that this and that is not harmful in oncology patients, in patients who receive immunomodulating therapies, ICI, but even diet, even normal diet, even plant-based diet has some immunomodulating properties. And we did a randomized controlled only 4-week study where we compared 4 weeks vegan plant-based diet with meat-rich diet, and we showed that the number of white blood cells, granulocytes, monocytes, platelets was significantly going down in the vegan group and was a bit going up in the meat-rich eaters, and the difference was significant. And as a potential modes of action, we see that one is the prostanoid metabolism, so prostaglandin formation related to arachidonic acid. Also, the mTOR pathway is involved in diets. This pathway, which is targeted by medication, is also targeted, of course, in an only small amount by diet, and of course, what Dr. Schwarz already said, microbiome related. So we have microbiome related immunomodulating changes just by diet. And green tea, also something it's very common, everybody, not everybody, but many people are drinking green tea, is affecting a whole branch of signaling pathways, NF-kappa B and the JAK-STAT pathway and ROS, of course, and this mTOR pathway also has been shown, at least in vitro, a lot of knowledge that this epigallocatechin galeate from green tea is modulating our immune system. So you find it everywhere. You just have to look, and you will find at least in vitro studies which show to any plant you want to see has some immunomodulating properties. And a very common immunomodulating pathway, as I already mentioned, is the prostanoid formation pathway. And for example, the devil's claw, which is used for pain treatment, contains hypocoside, and it's shown that it modulates the COX-2 enzyme, the lipoxygenase, and the nitric oxide synthesis. The stinging nettle has been shown, caffeolic acid, that's also reducing COX-2 activity, and even has an anti-TNF-alpha effect. Arnica is a triptophan, is acting on the NF-kappa B pathway. And evening primrose oil, gamma-linoleic acid is modulating also COX-2 activity. So it's all, of course, this is more the innate immune system, but it has some immunomodulating effects. And now one plant which is mentioned in the guidelines for its action on cerebral edema. So this is the Boswellia serrata, the gun resin of the boswellic tree, and it's also working on this principle with lipoxygenase modification. And this has been active in a clinical trial in patients with brain metastasis and could reduce the edema in a high dose. And this is the reason why in the German guidelines, this is of course now in German, sorry, but that's in patients with brain tumors and brain metastasis during radiation therapy, that this Boswellia serrata extracts can be, this is a can recommendation, can be given in supplementing the normal treatment, and this has anti-edematous effects. We have from all this, we don't have clinical trials on interaction, but we have at least here the proof of an effect, whether this is related to this LOX or immunomodulation, or it's just it's other effects we don't know, but this has been shown in clinical trials. So lavender and passion flower, ginseng and rosewood, rhodiola, cannabis, and capsaicin and valerian are all used quite frequently in cancer patients. Also in our outpatient center, we have an outpatient center visited by about 1,000 tumor patients per year. And I only go through a few examples because it's just too much to present it all. Valerian is quite interesting. It's not in the guidelines, that doesn't have a positive recommendation, but I think we have an interesting, it was a phase 3 study published 2011. The primary outcome, actually the sleep quality, the PSQI, was negative. There was not improving sleep after 4 and 8 weeks, but fatigue was significantly reduced. If you compare valerian with placebo and look for the fatigue, this is a baseline that was about the same in the two groups. But after 4 and 8 weeks, fatigue now and the usual fatigue both significantly reduced in favor to valerian. So, and this is quite interesting also from phytomedicine, because we always say valerian is something which is stabilizing a bit our vegetative nerve system, and it's not sort of making us tired and fatigued, but it's more focusing our attention, and that would actually fit well to the notion that it's reducing fatigue in cancer patients. It was a secondary outcome, therefore we can sort of have it as proven information, but so this is at least quite interesting. What do you think? Does valerian have any immunomodulating effect? So far, probably nobody has read about it, but of course there are studies here, even from people working with me. They published that effect of valerian and other herbal extracts on the stimulated human lymphocytes, and you see here in concentrations from about 10 to 30 microgram per 30 microgram per milliliter, is reducing the activation status of lymphocytes. So we have an immunosuppressive effect even of valerian, but in concentrations, they are low, comparatively low, but by far not as low as what Professor Binder used in her experiments. I was looking, she used 2 nanograms of her antibody conjugates in these experiments, and this is 30 micrograms, so it's more than 1,000-fold difference. And this also you have to take in mind, consider, when you are talking about these immunomodulating effects, we also always have to consider the concentrations which have been used. Yeah? And these concentrations, they're all in vitro experiments. Probably in vivo, you have to eat at least 500 grams of valerian probably to have the effect. Yeah, cannabis has been covered in one of the groups this morning, and cannabis is involved in the cannabinoids is in a lot of receptors here. It's not only the cannabinoid receptor 1 and 2, but also the TRPV receptors and others. And all these receptors, they have certain relation to the immune system. For example, the CB2 receptor is on mast cells and lymphocytes. VDAC receptor is important for regulating apoptosis. This is a heat receptor, is important for thermoregulation and local blood flow and phagocytosis. So cell migration. So a lot of immunomodulating properties also related to cannabis. And cannabis is interesting now. Is in the guidelines. We have 2 indications for cancer patients. One is it's a low recommendation, no recommendation, but it's a can be. There is some evidence that that we can reduce pain in cancer patients, and there's some evidence from randomized trials that it's reducing it's reducing nausea and vomiting in cancer patients. So that's actually where it can be used. And but if we look on the data now in the combination treatment with checkpoint inhibitors, the data are so that cannabis use in combination is related with a poorer progression-free and overall survival, not from randomized controlled trials, we have to say, but from experimental studies. This has been done in mice, and then this is a retrospective study also with a poorer outcome, and this is a prospective observational study made in Israel with 100 patients, and but the outcome was less, but the symptom scores on the quality of life was better in the patients with cannabis use. So we have an even better quality of life, but maybe, we don't know it, because it maybe also said the patients who had a worse performance were using the cannabis because they felt worse, and then you have, of course, a bias. It's an observational study. It was not a randomized control study, but at least we have some indications that it might have an interaction. Yeah, another plant which is in the guideline is the ginseng, which contains tritipin, saponins, and this is a study which is used in a concentration about 2 grams per day, American ginseng, for the improvement of fatigue in cancer patients, also a CAN recommendation. And ginseноids also have a lot of mechanisms of action here on the ACT pathway, on autophagy, and on survival of cancer cells and others. I don't go into detail here, but just to show you there is information, and it's also, of course, immunomodulating. And we don't know exactly about the clinical data, but probably it's again a big gap in with dosages. And black cohosh, is used for treating of like menopausal symptoms, mainly heat flashes in breast cancer patients during anti-hormonal therapy, and has also a CAN recommendation. And also this, it has some immunomodulating effects, different here. The thing is that it's interacting with the nucleoside transporters of the plasma membrane. That means if you treat here prostate cancer cells with small doses, 1.4 microgram per milliliter, this is a low concentration, then you reduce the uptake of a nucleoside into the cell, and that has been shown for the cell, but also it has been shown that some chemotherapies like gemcitabine and 5-FU, they are less incorporated into the cell. Here, the IC50 of 5-FU is different in PC3 cells during the mock treatment and the treatment with black cohosh. It's a 10-fold different, and this is gemcitabine. And it reduces the cytotoxicity of gemcitabine in these cells. So you see here the mock treatment, and you see here the gemcitabine, and it's really, there is a difference. So there might be an interaction. We only know it from preclinical studies, but this is something because it's in low concentrations, so that should be, from my opinion, should also be investigated in clinical trials. Otherwise, with the hormonal treatment, there's no risk of interaction as far as we know so far from clinical studies. And ginger is very common, also frequently used in different forms as tea and as herbal extract. This has a level of evidence 1, but also only can recommendation to treat cytotoxicity-induced nausea and vomiting again. And ginger also has a lot of immunomodulating actions, mostly on the COX-2 pathway, what we already had of the innate immune system and the prostacyclin formation, but also NF-kappa B here, and also on the T cell level a little bit less. So we have this, but I think this is probably not relevant because the dosages used here have been high. Curcumin, probably all of you know, many cancer patients use curcumin, and curcumin is a bit suspicious because curcumin is really acting against everything. And if you look, there are thousands of experiments done that curcumin is affecting anything in any assay. And I found this very nice overview here in a good journal that they name curcumin a pan-assay interference agent, a PAINS. That is something which has a lot of unspecific effect when given to in any assay, because it's aggregation, it's aggregating proteins, it's covalently labels proteins, it does metal chelation, it disrupts the membrane, it makes a structural decomposition. So it's something which is sort of affecting anything, and if you do it in control, you get a positive results. And here is very interesting. This suggests that any report of its activity in an assay that does not exclude or account for these modes of action here should be treated with caution. This is a very important consideration for reviewers also, because nowadays curcumin comes more and more, and yes, this is a promising, very promising and so on drug, but maybe this is all biased by neglecting that it's actually a pain, that it's something which is acting for everything. And we have no clinical studies so far that it's working. We have some studies, but not in oncology. And a plant which is from my perspective even more interesting, and here you see this is not a pains, this is Artemisia, not annua, this is Artemisia argii. Actually, this is a Chinese herb which is used for moxibustion in Chinese medicine. And you said, for example, in this pathway, this is the AP1 pathway, it's not effective, but in the NFAT pathway, it's working in low concentrations of about 10 microgram per milliliter, and in the NF-kappa-B assay, it's also working even with 3 microgram per milliliter. This is sort of a very low concentration for plants. Actually, for a whole plant extract, it's a very low concentration. And this is something which should be further investigated. It has been here also in melanoma cells been investigated, also shown that the ACT pathway is inhibited. But we also, clinical data are lacking. Probably you know that the German drug law is very difficult, and it's not easy to make trials with herbal medication in Germany. They do it in China or in Iran, but in Germany and in Switzerland a bit less, it's difficult. Now to the plants which are specifically actually designed to be an immunostimulator, like the mistletoe. The mistletoe also has a CAN recommendation in the S3 guideline. Subcutaneous injections from mistletoe extract can be used for improvement of quality of life in patients with solid tumors. And we actually don't know exactly why the quality of life is enhanced, but what we definitely know from placebo-controlled studies, sorry, this is only a single slide, but there's a lot of placebo-controlled, even patient studies, which is sort of the base for this. We know that mistletoe preparations in placebo-controlled studies in healthy people increase the number of neutrophils, of white blood cells in comparison to placebo. This is true, and this is related to the lectin content. And we know also from placebo-controlled studies that it's stimulating B cells, and that in the end, mistletoe lectin antibodies are produced by mistletoe extract. We know that it's stimulating dendritic cells, that is sort of resorbed by antigen-presenting cells, and is stimulating dendritic cells, affecting lymphocytes, and then shifting even the immune system, the immune response of the adaptive immune response to more actually to a T helper 2 response by producing interleukin 5, and in the end by you see an eosinophilia. And those of you who have to deal with mistletoe treatment, and if you monitor your differential blood count of your patients, then you will see that those who have a higher lectin, mistletoe lectin treatment, they will have eosinophilia. But we also have shown in another study, also a placebo-controlled study, that even the T helper 1 cytokines like interferon gamma are increased. So it's actually increasing both the T helper 2 and the T helper 1 response on the specific immune system. Yeah, and the question is, of course, this immunomodulating effect of mistletoe, which is, from my perspective, very clear because it has been shown in clinical placebo-controlled studies. The question is, where can this be utilized for cancer patients? And one idea is from Wilfried Tröger, that he did it in patients during chemotherapy to reduce the number of neutropenias. So but we don't have big studies for that. We only have it as a secondary outcome. And one study is this year. These were 100 patients with mainly breast cancer, and then we have patients with neutrophils less than 1,000. And you see that in the group having the mistletoe treatment was 59, and from those we have 3, 6, 9, 10 with a neutropenia from less than 1,000, and the control group with 30. We have 3, 6, 9 with the neutropenia. The difference was not statistically significant, but it was at least a few less patients. So this would be something which also from my perspective should be investigated more. We don't have larger studies investigating this. What the safety in combination with ICI is concerned, we have data from register studies from Berlin. And this have been about 240 patients, and either they had a combination therapy with an ICI and mistletoe, or they had only the checkpoint inhibitor therapy, and then they monitored the side effects. And you see that the side effects, all in all, the total number of AEs was very low, actually 10 only in this group, and they all occurred in this only ICI group. And even the number of patients who had to stop this therapy was low. It was 0 in the combination therapy group and 5 in the only ICI or targeted therapy group. So this is, of course, not sufficient to say that it's sort of what it is, but there's no hint, there's no signal that mistletoe has any negative impact on interaction from my perspective. Yeah, mushrooms is just to finish with. This is other entity of substances. Mushrooms are not plants, you know, they are mushrooms sort of, and they are from the immunomodulating perspective, they're very interesting. They also they interact with a lot of different pathways. You have already heard NF-kappa B signaling is important for inflammation. Pathway is important for cancer development. So in general, they work on this, and the main ingredients is actually beta-glucan, and this is just to show you it's interesting. One of these beta-glucans, lentinan, is an approved drug in Japan for treatment of cancer, and the immunomodulating effect probably originates in the similarity between the the beta-glucan and the surface of bacteria, like LPS-containing bacteria. So this is a molecule of LPS, and if you look here at the structure of this carbohydrates, and you see there's a certain similarity, and this is sort of like a warning signal, a stimulating signal for the body. Oof, there might be, and if you have these substances coming to the body, there might be something dangerous, and then the immune response is stimulated. But also from here, we don't have clinical trials. So, this is actually the data I wanted to present you. And in summary, most herbal extracts, maybe all, have immunomodulating properties, at least in vitro. And numerous signaling pathways are involved, all very nice, interesting signaling pathways, but mostly, of course, in concentrations which are sort of not really transferable to the situation in vivo, and we have only almost no in vivo studies. There is a huge gap in knowledge between what we have in vitro data and those from the clinical data. So the clinical relevance of the immunomodulating properties in cancer patients has really been investigated, and we have not yet clearly shown for any extract. So we don't know what the... Of course, we have some indications. I showed you this has in the guidelines. It has a CAN recommendation for nausea, pain, this and that. But from the immunomodulating potential, this has not been clearly shown for any extract. And what the safety is regarded so far, there's no major safety concerns for common herbals used as supportive therapy in cancer patients from clinical experience and from register studies. That's what we have so far. And this is here, if you want to know about interactions, and you can go to this site. This is from the Cancer Center and in New York, and this is this site has quite good information about interaction of herbals. Thank you very much for your attention. This is Freiburg University Hospital. We are here, located here. Actually, this is the cemetery, and where this is the other side, and so we're just in between. And so this is one part of my team from the clinical part. Yeah, thank you very much for your attention.
So we need to make more research. We need to make more control trials.
Yeah, that's a question, actually. Do we really need to make clinical research for each of these drugs, or even if even the normal nutrition affects our immune response? How can we say then that could be dangerous? Or would you, in the end, ask the patients not to eat plants and not to eat broccoli and not to eat this? Because... And what I think we are a bit over-exaggerating, so we are overestimating the side effects. And and then we are very, very cautious what this is regarded. Yeah. But on the other hand, the effects, even if they have been shown in vitro, clinically, it's probably low. And I think even that nutrition and diet have a stronger effect than the herbals, because nutrition, if you eat a plant-rich diet, this is really grams. This is hundreds of grams. But the herbals, if you eat 1 gram of ginseng or a bit of valerian every day, milligram range, how could that affect the immune response if you have something in vitro, but it's not in relation to what you can clinically take up?
Thank you. Any further questions?
Thank you for your presentation. You might have not mentioned intentionally St. John's wort, but let me ask you anyway. I'm running a psycho-oncology clinic within my psychiatric department. And I just wonder, how careful do we have to be by prescribing St. John's wort as an antidepressant to patients who are receiving chemotherapy or immune modulating therapy? Are there any studies about the interaction?
Yes, there are. So St. John's Wort I didn't mention, very consciously, because this is out for cancer patients. So I would not recommend St. John's Wort for cancer patients, at least not in dosages which are effective clinically. That means 900 grams or more for treating moderate depression. So if someone drinks a tea from St. John's Wort, this is, from my perspective, not relevant. But if it's a standard preparation, high dose, we have too many, not only reports from basic research, but here we even have clinical data that the effect of certain, for example, immunosuppressants like cyclosporine and others are affected. So there are case reports, and that if patients take St. John's Wort, that the effect of, for example, cyclosporine is significantly, drastically reduced, and if I stop it, then it's going up again, and this is because it's of the metabolism of the liver, of the cytochrome peroxidase. So this is relevant also for a lot of cancer drugs. So actually the risk is too high, and we should use other things for treating depression, for example, like rhodiola.
Yeah. May I expand on that? We have a company, a plant-producing company in Switzerland, who has produced an antidepressant where they claim it has a very low level of hyperforin, which is responsible for the interactions.
Yeah, that should be investigated first in vitro, and if you don't have an interaction in vitro, then you are on the safe side.
Thank
probably.
you.